Hello and welcome to today's class. This class is about the best restorative materials for patients with bruxism. If you're a dentist watching me right now and you do restorations in your office, whether it's a few days a week or every day, I don't know how often you see patients, but I'm sure you do like curing in your practice and have questions about materials. And this week, I'm running a preparatory week. I've done a live session every day this week. Today is Friday, and this is the last topic in the preparatory week for next week, which is the advanced dentistry week, where I, as a dentist, will teach you how you can become a reference dentist in your region, increasing your revenue with great integrity through differential diagnosis, treatment, and management of bruxism. This is for you who don't charge for consultations, for you who do charge for consultations, for those who accept health insurance, for those who don't accept health insurance. This is for any and every dentist who provides clinical care. The Advanced Dentistry Week is free, but you need to sign up because it won't take place on my social media like this preparatory week did. So enter your best email in the link in the bio. There you'll find the link to receive the registration website. Enter your best email there, put your WhatsApp number, and join the group. For those of you on YouTube, the link is here in the comments in the description. And you go there, join the WhatsApp group, and don't leave. Why? Because that's where I'll be communicating. That's where I'll send materials. That's where I'll send PDFs, articles. That's where I'll equip you with tools to face this problem that keeps growing called bruxism in your practice. And with that, you'll become a reference dentist in your region because you'll stand out. For those of you who don't know me, my name is Andre Mello. I'm a dentist, graduated from UARJ. I have a master's degree in materials science from IME, a doctorate in operative dentistry from UARJ, and I'm a prosthodontist and periodontist. I see patients every day in the office. I do restorations. I do rehabilitations. I know what it's like to balance academic life, articles, publications, and teaching with the life in the dental office. It's not easy to combine science with clinical practice. It's not easy to see patients every day, but I know you face this every day. And I want to bring you the important information so that you can be part of this movement, which is the Dentista 360 Degrees movement. For those of you who don't know me and are looking for my publications, I'm listed on the CNPQ search site, which is the Latte's curriculum, the researcher's CV for anyone who wants to look me up. And let's get to the topic of the lesson. What are the best restorative materials for patients with bruxism? And I want to share with you all this expertise in materials. I've always been very interested in materials, which is why I went to an engineering school, the Military Institute of Engineering in Rio de Janeiro, one of the most renowned institutes in Brazil and in the world, with a very high level of scientific research. And I spent a long time studying zirconia, disilicate, all these restorations, polymers and resins. And I want to point out to you that it doesn't matter whether you're doing single units or extensive rehabilitations. You need to understand that materials will fail if you have a patient with an overload, such as bruxism. What happens? Bruxism is an amplifier of problems in the oral cavity. I want to share with you some definitions about types of materials, about their differences, and today I'm going to prove to you that even with the best techniques, one of the most resistant resins, the best adhesives, the clinical protocol, away from saliva, dry, following every single step, I'm going to show you all of this today. I'll talk about the strength of restorations, and I'll show you what has already happened to me in terms of failure. I know it fails because it has already failed in my own hands. And I know that many times you see patients with restorations that aren't lasting in your clinic, or patients where you don't even know if the restoration lasted or not because they left and never came back. And the point here is this: a patient who doesn't stay loyal is because they didn't see value in you. They didn't see enough value in you for them to stay loyal and never look for another dentist again. So my question is, what kind of dentist do you want to be from now on? If you make a contract stating that after an endodontic treatment, for example, the tooth has become fragile and may fracture, and you protect yourself with a contract about dental fragility, my question is this: do you actually want that tooth to fracture? I'm sure you don't. Nobody wants a tooth to fracture, but it can happen. What can we do to prevent these failures and fractures? Because it is possible to prevent these failures and fractures. And I know you might be thinking about a mouth guard right now, but I want to tell you that a mouth guard is this right here. Look. It's actually part of the treatment for bruxism. And many times you're focused on having the best resin, having high flexural strength, flexural resistance. Let me explain to you what flexural resistance is. It's the flexural strength test. You place a bar. You can use 2 supports or 1 support. And on this bar, we apply a force in the lab. Look how interesting. You make a bar with the material, with the resin. Here I have bulk fill resin, composite resin, flowable resin, CAD resin milled in the lab, and biacrylic resin. There are different types of resin. I'm going to talk about resin and I'm going to talk about ceramic in today's class. And then you make a little bar like this. Look, and you apply a force here, see? Bang, bang, bang. There's 3-point resistance and 4-point resistance. But I'm going to simplify. You place the bar here and bang, bang, bang. When this bar fractures, the point at which it breaks is what we call the flexural strength of the material. And that's what you're buying when you purchase a high-strength resin. You're buying the flexural strength of that resin. I understand, Andrea. So for example, a CAD-CAM resin, thank you. It has 273 megapascal of flexural strength. Is that right? Yes. And a flow resin, 110. That's why a flow resin is obviously less resistant than a CAD-CAM resin. And bisacrylic from 60 to 80. Of all of them, bisacrylic is the most fragile. Now, bisacrylic is made to be used during the provisional phase. I'm sure you have patients who fracture the bisacrylic because besides being more fragile, your patient might be putting extra stress on it due to something called bruxism. Bruxism is an amplifier of oral cavity problems. So imagine amplifying those problems with a C180 resin. So let me ask you, if the patient is using bisacrylic and fractures a central incisor, and you're having dinner with your family, you have to go back to the office to put that central tooth back in the patient's mouth. You can't just leave them with a fractured central incisor. They're paying for the treatment. Anyone who does restorations and prosthetics wants to avoid emergency problems because that wears you out, increases your anxiety. You could be anywhere in the world or just at home, and you're always worried about something breaking. If you're someone who's afraid of this kind of fracture, I want to bring you some solutions in today's lesson, and especially next week, which is Advanced Dentistry Week, where I'll teach you step by step about differential diagnosis, treatment, and management of buccinho. Now let's get back to flexural strength. I said it's like a bar, right? Think of a bar as something thicker, something straight with uniform anatomy. So here's the thing. When it goes into the mouth with a thinner thickness, like the thickness of a tooth, that flexural strength is even lower. Lower than the theoretical strength measured in the lab. Do you understand how we do it in the lab? In the lab, we test a bar. In the mouth, we have a tooth, a thin tooth, with an amplifier called Bruxism. So be careful because it's not the theoretical strength you see on the resin tube that you buy. It's much lower and much worse when we put it in a mouth with Bruxism. So let's go. Let's talk about resin. Resin has been trending lately. A lot of patients want to get resin. They don't want to get ceramic. Ceramic has gotten a bit of a reputation among people as artificial, as fake, like I don't want to have horse teeth. A lot of people say that, right? That has nothing to do with it, actually. You can do an excellent resin restoration and you can do an excellent ceramic one. It all depends on the operator's skill. That's another detail in today's lesson. The operator's skill matters. And on this point about the operator's skill, I want to say the following. Maybe you've been practicing for 40 years and you're worried about taking yet another resin course. But there's something in dentistry that we have to face, which is the fatigue of our body, the fatigue of our hands, the fatigue of our eyes. There's no way for us to escape that. As the years go by, we get older, and there's nothing we can do to change that. Fatigue in our spine, fatigue in our hands, fatigue in our eyes. And if you've been practicing for 40 years, I don't want to make you feel bad. Quite the opposite. I want to tell you that right now, there's an opportunity for you to come back stronger than ever and become a reference in Bruxism. Because Bruxism doesn't depend on your hands, your eyes, or your back. You're competing, let's say, on equal footing with those who might have more technical skill than you. You're competing on equal footing with people who might have a better eye than you. And I'll tell you even more, maybe you with 20, 30, or even 40 years of experience have greater sensitivity toward your patients because you've treated so many people in your life. You have more sensitivity toward your patients. So instead of worrying about the next technical course, it's time for you to get into Bruxism and understand how important this is right now, especially since we have so few references. Very few references and an enormous demand. Because out of every 10 patients who come into our office, 8 have some type of Bruxism, whether one kind or another. Now, coming back to resins, nanohybrid composites, which are the ones we use the most, they have a combination. Remember this name, nanohybrid? When you're at congresses or being visited by a sales rep or a dental supplier, keep this in mind. We are currently living in the era of nanohybrids with composite resins that combine nano and microfiller particles, offering a balance between aesthetics and strength. In the past, resins, if you remember the Durafil era, had excellent polishability, but terrible mechanical strength. They would break easily, no matter what. Great shine, but they break. Today, we have nanohybrid composites that combine polishability, aesthetics, shine, and strength. So these are materials used both for anterior and posterior restorations. Remember when we used to have Resin, those who are younger might not remember this, but we used to have resin specifically for the anterior region and resin for the posterior region. You couldn't use the same resin for both. I know there are people watching this class who remember that time when you had a bunch of different resins, some for front teeth, others for back teeth. Today, things are much easier. We have excellent finishing and strength. All right. I understand, Andrea. This micrograph here is showing the nanoclusters, showing the nanohybrids. And I want to show you a case from 2017 that I did using excellent high quality resins, top tier resins, Ivoclar resins, nanohybrid resins, resins with a high polish. I used isolation techniques, absolute isolation, to avoid contamination with moisture because resin does not like moisture. Remember, all resin is hydrophobic. Every resin-based material does not like water. So we need to do this. This was in 2017, as you can see on this slide. I followed the entire adhesive protocol step by step, drying as needed. Applying it there, you see vigorous application. Make a note of this. Vigorous application of the adhesive for better penetration, good polymerization, because the degree of polymerization also affects the material's strength. Make a note of that too. The degree of polymerization, the type of polymerization you use, influences the material's strength. I used imported resins, the sanding resins, okay? Resins with excellent mechanical strength and expensive material. I did all that, applied it nicely. That was the patient's tooth, but I didn't. I didn't have the perspective I have today, a 360-degree view. I just didn't have it. Maybe you're doing the same thing, taking a resin course to alter the vertical dimension of occlusion without doing a differential diagnosis for bruxism. And you're going to make an excellent resin restoration just like I did back then in 2017. Maybe right now you're unsure whether you should or shouldn't do this increase in dimension with resin for your patient, just like I did for this patient who had erosion, who had bruxism. And at that time, I didn't know how to diagnose it other than just looking and knowing there was some problem. I look at this mouth and say, yeah, he really does have bruxism, period. Today, I say he has bruxism and I know how to tell what type of bruxism when he does it, whether it's during the day or at night, how I can treat it and how I can control it, which is not a mouth guard because, for example, if I put a mouth guard on a patient with erosion without testing his saliva, and this is a patient who has a hiatal hernia, he's a patient with a corrosive level, and I put a bruxism mouth guard on this patient, what am I going to do? I'm going to make the corrosion even faster because I'll be pooling acidic saliva there for this patient to sleep with. And we know that resin is more soluble in an acidic environment than ceramic. Look how interesting that is. So if you're thinking like I used to think in 2017, I'll just give a mouth guard and everything will be fine. It didn't turn out fine. It didn't turn out fine, even though I used a composite resin with a flexural strength of 130 megapascals, which is good. For a small increase in vertical dimension of occlusion, only on the occlusal surface, an abrasion resistance of 300 is good. That's good. But do you know what happened? The patient developed bruxism, and the truth is, not including bruxism in the equation will leave you behind because that time is gone. The patient changed completely after the pandemic. The patient changed, life changed. In the past, we used to go to bed at 10 p.m. Now everyone is on their phone at 10 p.m., ending up with a bad night's sleep. And you wake up tired. I want to know which dentist doesn't wake up tired. And you start having headaches, fractures, loss of dimension. So you can't just turn a blind eye to bruxism and say you give a night guard and it's fine if it breaks because you warned them. That's not acting with integrity on our part. Bruxism is our problem. Dentists, bruxism is our problem. Doctors don't know how to treat bruxism. If you don't take on bruxism to treat it, no one will. So pay attention. It doesn't matter how long you've been practicing. It doesn't matter what your specialty is. Bruxism is what will set you apart today, wherever you are. The more you stand out in bruxism, the more patients you'll get, the more answers you'll provide, the more doctors will connect with you, and you need to open your eyes once and for all. So another case, back when I also didn't have a protocol, I brought this up because I know many of you see patients, for example, with class 2 malocclusion, such a common malocclusion in Brazil, followed by a posterior rehabilitation. Now look at this mouth, there's the jig. I did everything by the book, digitally. Digital or analog, it doesn't matter. Whether you do a digital or analog rehabilitation, you'll reach the same endpoint, which is restoring the vertical dimension. And I don't want you to give up your specialty. I don't want you to give up endo. I don't want you to give up prosthetics. I don't want you to give up any of that. I want you to include bruxism, just like I did in my own life and as dozens, hundreds of my students have already done as well. But I want to show you the following. This is a patient who had a loss of vertical occlusal dimension, who had an alteration in this dimension, class 2. So we did the restorations. I'm talking here about cemented material that is made in the lab. And I also just mentioned direct resin to you. Rehabilitation with direct resin, alteration of dimension with direct resin. And then with the entire project done in Exocad, the lab that works with you today probably uses this software, which is the most common one. So we are going to proceed with the rehabilitation. This was the change in dimension. An excellent technician from Southern Brazil. Let's move on then to the cementation of the case, the step-by-step checklist. Let me make a side note for you here. It is cemented on enamel. Cemented on enamel, it has much greater strength. Remember that. Every time you cement ceramic, try to do the cementation on enamel or have the margin on enamel, as much enamel as you can, because the flexural strength of the whole set will increase. Ceramic bonded to dentin. Dentin is soft, dentin is flat. Ceramic is not. Ceramic is hard, rigid. So remember that the more enamel you have, the more you increase the strength. Now, removal of the provisionals, cleaning, try-in of the piece, try-in one by one, then try-in of the adjacent ones. You should always follow this sequence. Check the fit and occlusion if everything is fine. The flexural strength of Emax is 540 MPa, 540 MPa. Remember that the resins was 130. We went up to 540 MP, almost 5 times more, 4 times more. Emax, lithium silicate, the most resistant ceramic for single units where aesthetics are involved. All right, I get it, Andrea. It's monolithic, okay? It's not layered, it's monolithic. Then I'm going to choose the cement. I'm going to pick a good cement, right? Of course, I'm going to choose a good cement. I wouldn't risk my restoration. Maybe you're thinking, if I use this cement, it'll work out. And then I use a cement with a maximum thickness of 1.5 millimeters, so it can be light cured. Polymerizable, the thickness of the piece. If it's more than 2 millimeters, like you see there in the specimen, if it's more than 1.5 millimeters, if it's up to 2 millimeters or more, then we're going to use base and catalyst. So remember, write this down. If I have up to 1.5 millimeters, I can just use the light cured cement. If I have more than 1.5 millimeters, more than 1.5 millimeters, 2 millimeters or more, always use a catalyst because the light doesn't penetrate. All right, got it. The light doesn't penetrate photopolymerization, and now I'm going to photopolymerize and feel at ease. Why? I did a photopolymerization. I used a good cement, used a good polymerizer, made a 540 MPa ceramic. Everything's fine. Cemented it on enamel. Everything's great. So now I'm going to do the digital occlusal adjustment beautifully so that we don't have any problems with load distribution. I'm going to make everything perfect. I did everything beautifully in 2015, 2019, and this case kept me up at night. Maybe you're dealing with a case that's keeping you up at night. And if you have a case that's keeping you up at night, I want to tell you, this case kept me up at night. Do you know why? I did everything by the book. Maybe you do everything by the book too. And 2 years later, it failed. It failed on the canine. Look at the canine. She wore down the canine. She wore down the canine. How did she wear down the canine? Bruxism. I removed the bruxism. I didn't have bruxism in the equation. I had the best resin. I had the best polymer, the best cement. I had the best ceramic. I had the best curing light. I had adhesive cementation. I had a dry environment. I had the best technician, and it still failed. And then you say, but it's the patient's fault. Sorry, but I don't accept that. It can't be the patient's fault if I'm a healthcare professional with integrity and I can't provide a solution for my patient. And that's when I started losing sleep and said, this can't go on. You can't get the equation right. You can't make the correct occlusal adjustment. You can't live with this kind of stress. And whose fault is it? The patient is going to be upset. The patient won't want to pay. The patient will make you redo the work. Soon you'll be paying to work. You bill 20,000 and spend 18. And this starts to become a problem in your life. And the profession that was supposed to be rewarding starts to become stressful. So I want to tell you, if you think that just giving the patient the splint or that if it breaks, it's the patient's problem, I'm sorry to tell you that your future in dentistry won't be good. Do you know why? Most patients today are grinding their teeth. And what can we do about this? The moment is, remember Popeye? When Brutus would go after olive oil, Brutus would try to mess with Popeye, grab olive oil, and Popeye would turn and say, no, 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 that's it. I can't take it anymore. That was his moment. I can't take it anymore. That's what he would say. I can't take it anymore. He'd grab the spinach, eat the spinach, get strong, and go beat up Brutus. Regardless of the parenting philosophy you follow, whether it's right or wrong, that's not what I want to discuss, whether it's a good or bad cartoon. What I want to say is this. What is your moment, Dad? When is the moment that you can't stand to see something anymore? if you're tired of leaving the office late, if you're tired of not having time for your family, if you're physically exhausted because dentistry drains you with that many patients, if you're tired and don't want a certain thing in your life anymore, if you're tired of seeing teeth breaking, patients complaining, patients disappearing, patients not responding, it's time for you to have your moment to take control and turn things around in your practice, for you to become a reference in your region. And then from the moment I said, that's it, I can't take it anymore, I need to have an answer for this patient. I wanted to have an answer for this patient. I dove in head first. I studied a lot. I put it into practice. I tested it on dozens of patients. I supported it. I followed the entire protocol. I published it. Why? Differential diagnosis, treatment, and control of bruxism, a methodology where the patient is in your chair, and this is the greatest opportunity of the decade that depends only on you. So the diagnosis, the D for differential diagnosis, here is a complementary differential exam, the diagnostic splint exam that I published in 2019. It was precisely when those rehabilitation cases started to fail, and I did not want to see that happening in my office. So I published this, applied it to this patient. She was one of the first to receive the diagnostic splint. And on this fractured canine, I put her diagnostic splint on. It is an exam that you put on the patient for them to sleep with. Pay attention, it's not that you want to see the tooth moving. When you order a CT scan for a tooth that needs a root canal, you don't want to see an accessory canal, or you don't want to see a fractured tooth. Do you? You hope everything is fine? You hope there isn't a problem. That's what the diagnostic splint exam is. You hope there won't be a problem, but you have to do it for everyone. Because if something does show up, like it did with this patient, I needed to know what she was doing, what had caused that damage to her canine. She wore it down because she was grinding her teeth. If she wears down her teeth, why wouldn't she wear down a restoration? So I started bruxism treatment for her. With this splint, I can see that she has eccentric bruxism, meaning she grinds with movement. I can see from this splint that she has bruxism with high intensity, in other words, advanced bruxism. This will guide the type of treatment I choose, because not every patient is the same, and not every bruxism treatment will involve the same supplementation, which is one of the steps in the treatment. And this really determines your future in dentistry. What are you going to provide for this patient? Just a splint? And what about the day when he doesn't want to use the splint, or he's not in the mood, or maybe he just forgets because he thinks he doesn't do it anymore? He hasn't even checked if he still has bruxism or not. I'm going to show you all of this about treatment, about the different complementary exams, about everything we're experiencing and discussing here, this entire step-by-step process of DTC, differential diagnosis and control treatment during Advanced Dentistry Week. I'm waiting for you. So after performing the diagnostic splint exam and all the different complementary exams, I'm going to explain to you what the other complementary differential exam is during Advanced Dentistry Week, which I applied to her. I added a layer of light cured resin, 130 MPa compared to 540 MPa for ceramic, the actual treatment for bruxism. The case was finished with resin. I didn't replace the ceramic. Here you can see the lack of polishing. In fact, it lost its shine over time. But after 2 years, she still has the resin. I did it on purpose. I wanted to leave this resin treated for bruxism. I wanted to keep it to see how long it would last. So the ceramic didn't last a year, but the resin lasted 2. It's actually lasted more than 2. We've already gone beyond that. So what does that mean, folks? That the treatment for bruxism made this patient, her awareness with the diagnostic splint exam, and then starting a real bruxism treatment, reduce her nighttime and daytime movements. Because in her differential diagnosis, I saw that she also made movements, that she had daytime clenching. In short, it can be resin or it can be ceramic. It depends on how healthy your patient is. It depends on how much real bruxism treatment you've done for them.
And then my diagnosis was always a mouth guard. But after I learned about Dr. Andrea's DDC method, even though I wasn't charging for the initial consultation, I went from 0 to 450 rays, because now I'm charging for the diagnostic mouth guard. And the full diagnosis, which includes polysomnography, now goes from 0, since I didn't charge anything before, to 1,350 rays, with the entire diagnostic package included. This part of the diagnosis, I honestly thought it wasn't possible to close it in the first consultation. But there's so much knowledge that we acquire, and during that first consultation, we share all of it with the patient, that the patient becomes convinced that this diagnostic stage is extremely important and doesn't even question it. They don't even question what comes next. They say, let's do the diagnosis. Let's first find out what you have, and then we'll come up with an individualized and personalized treatment plan for you. The methodology, The materials that are used aren't anything extraordinary, so they're straightforward things, simple, not expensive, and you can add value to this exam. So, from general practitioners to specialists, I think it's really worthwhile to include this in your clinical routine because it will help with the final result and the overall delivery of the treatment for the patient. Today, I feel like a reference in my region because patients come in and are amazed by this whole methodology we're applying here. And that makes me extremely happy because that's what I've always sought throughout my clinical career, to deliver this to my patient in the form of a treatment that will help them have a better quality of life.
And it's about that difference in diagnosis. It's about you who have a lot of patients in treatment, like I had with this patient who had finished treatment but came back with fracture problems. And then I apply the differential diagnosis to her, do the restoration or replace the restoration. It's not just for the first appointment. It's for the patient who comes in with some problem, or for the patient who comes in needing any kind of treatment or is in the middle of a treatment. And you're going to tell them that now you have the technology to do a nighttime exam on them to know whether they are grinding or not. So it's for all patients. And it's at this moment that you increase your revenue with a lot of integrity, because you're going to do an exam that the health insurance doesn't cover. You're going to do an exam that the health insurance doesn't cover, and your patient who doesn't pay for the consultation will pay for the exam. So it's this methodology that I'm going to teach you during Advanced Dentistry Week. And I wanted you to hear from my student who, just like you, is watching the classes, what she has already managed to transform in her practice after applying this methodology. Look how cool that is. This will help the patient have a better quality of life. And I started today's class by showing this case. I gave him the mouth guard. In 4 years, he also destroyed the composite resin. And after I had the methodology, I also applied it to a case that was failing. I applied differential diagnosis, and look at that. He's showing what he does during the night. Look at the canines. Look at the canine movement, eccentric and eccentric bruxism. He makes a short adjustment. See, he points in the canine, doing his adjustment. A repetitive movement, which is bruxism with eccentric movements. Eccentric movements, easy movements, as we say, these are easy. Very well. What did I do after applying the differential diagnosis to this patient and treating his bruxism? Shall we replace these resins with ceramics? No. Look at his canine. I'm going to replace it with injected resin. For a while longer, now I want to see how this injected resin will behave after the bruxism treatment. And look how interesting what happened, the whole step-by-step modern techniques. Are you young and want to use modern techniques? That's fine, as long as you treat the bruxism so you can monitor this patient. Guys, flowable resin on the canines. Flexural strength, 110, lower than the composite. Abrasion resistance, 250. The composite was 300. Injected resin, the composite resin he destroyed. The injected one he didn't destroy. Why? Post-treatment. I'm going to show all of this during Advanced Dentistry Week. The treatment part, supplementation, the stages of the treatment. And then the patient said that this changed everything completely. Today, she's able to wake up feeling better. It changed everything. And let's move on to another student who is a prosthodontist who also used to recommend the splint. Look at what happened in her life.
Doctor, am I going to have to use this mouth guard for the rest of my life? And I used to fit that mouth guard already worried that the patient would break my work. After learning Dr. Andrea's DTC method, I started to see bruxism and clenching in a completely different way. The number of cases I recommended it for doubled. So now when patients come to me, I see things differently. I charge 200 reais for the bruxism consultation and 450 for the diagnostic mouth guard exam. So now I am the go-to person for bruxism in my city and my region. I've already seen results with the diagnostic mouth guard, with the treatment, and with follow-up. So I've managed to attract many patients and many referrals, which is also the most important thing when you are respected in the field.
I want to tell you that next week is Advanced Dentistry Week. Stop just giving a splint and thinking that's bruxism treatment when you have a huge opportunity right in front of you to become a reference, to make a difference, to increase your revenue with a lot of integrity. So even if today you don't have appointments or you work with health insurance, don't forget, put your best email, set aside an hour each day next week to be with me, to invest in yourself. The preparatory live sessions from this week, including today's, will go offline on Sunday. They won't stay up there forever, okay? They'll go offline on Sunday. So if you want to watch the classes that happened on Monday, Tuesday, Wednesday, and Thursday, binge them until Sunday. It will definitely be worth it. And on Monday, I'll see you at Advanced Dentistry Week. Don't leave the group. Messages will be sent by my team, who are the group administrators, okay? Don't forget that. and I'll be in there waiting for you. Kisses. Thank you so much to everyone who was with me all week. We are ready to dive headfirst into Advanced Dentistry Week on Monday. Don't forget, the preparatory classes will go offline this Sunday.